Bueno, muchas gracias, Pierre. El profesor Pierre Singer no se encuentra conectado, por lo cual no habrá posibilidades de hacerle preguntas. Quien sí está conectada y tenemos su conferencia grabada es la profesora Mette Berger. Para nosotros es realmente un placer y un verdadero honor poder contar con la presencia de Mette en nuestro Congreso. La doctora Berger es profesora de la Universidad de Lausana, en Suiza. Es la former head de la unidad de quemados del Hospital Universitario de Lausana. Es la chair de la Men's Section de la Sociedad Europea de Cuidados Intensivos, miembro de las guías de la ESPEN y de la Sociedad Europea de Cuidados Intensivos, así como también la líder de la sección de micronutrientes de la Sociedad Europea de Nutrición Enteral y Parenteral. Mette nos va a hablar sobre el estado actual del conocimiento de los micronutrientes en los pacientes críticos y cuál es la evidencia más reciente con relación a este tópico. Adelante.
Good morning, dear colleagues. I am Mette Berger from the Lausanne University Hospital. I'm an intensivist and a nutrition specialist. And it's an honor and a pleasure to share with you what we know about micronutrients in critical illness over the last years. Well, first, let's start with the conflicts of interests. I'm lecturing for several companies, but nothing will influence the actual presentation. Well, what characterizes the critically ill patient? There is an intense oxidative stress in the realistic ones. There is inflammation. There is depressed immune defense, often micronutrient losses, and actually higher than usual nutrition needs. There is catabolism. A colleague of us, two colleagues actually, made a summary of what we know about deficiencies in critical illness, and actually said that the status of our patients was challenged by the disease, but also by the therapies we have to use in the critical care setting. And he summarized the micronutrients being first thiamine, zinc, B12, folate, iron, vitamin D, vitamin A, vitamin C, but also selenium, of course, and potentially carnitine. And this is due to pre-exposure to disease or actually to our treatments. You see, these are quite several. What happens to our antioxidant and immune defense? Well, increasing disease summarized with the Apache 3 here in this case, it's associated with an increase of myeloperoxidase, which reflects oxidative stress, and a mirror decrease of plasma redox status. And this matters to our patient's micronutrient status as it is a web. And this is maybe one of the important messages of my presentation. It is that we don't have a solo single magic bullet. Look at this as normal physiology. And what you observe is that in the core of it, you have a combination of actually lipoic acid, ascorbic acid, vitamin E, iron, etc. They work together. And if you only give one of them, you just put everything out of balance. And they have different roles. They work together, yes, but some of them are chain breaking, mainly vitamin C, E, but also glutathione peroxidase. They can be involved in repair, it's folate, it's zinc, B12. They are involved in prevention, superoxide dismutase with copper, zinc, selenium, catalase with iron, and they all must be provided by diet. And it's the same game for immunity. A very important paper that I encourage you to go and read, because it's very well referenced, shows that actually micronutrients are involved in all steps of immunity. Physical, with the skin barrier and mucous barrier function, the innate immunity, the adaptive immunity, I won't read all of this to you, but it's really all well documented. In the physical barriers, you have a combination of these vitamins and iron and zinc. In the innate immunity, the oxidative burst and protection is under control of vitamin C and E, iron, zinc, etc. Immune proliferation, antimicrobial. See, there is never one single one. The inflammation is part of the defense, and it is under the control of trace elements and vitamins. The adaptive immunity is also under the control of a series of micronutrients. So there's been long a very important confusion between having a deficiency and wanting to correct it, or to deliver a single bolus and pharmaconutrition. So this has led to actually a mess in the concepts. The micronutrient status of our patient on admission is compromised by various things: the eating patterns, the eating just before admission, the disease itself. And you probably have seen these data from Nutrition Day, where there are 10,000s of patients, and you look at what's happening just on that day. And the patients who have been eating as usual are actually less than 50%. Many have been eating just a little, or we don't know. And this is even worse because there is an increasing mortality with increasing deficit. We also know that there is a relation between the vitamin D status and survival. This is a paper which is under handling, and it includes 150 patients, and it looks at survival at 90 days. Well, if you have a very low vitamin D status, which is something which in these ranges is probably reflecting deficiency, then you survive less. And this matters because it's about defining the cutoff for doing something. And this is true also for ascorbic acid. All data already, but they all consistently confirm the same thing. If you take patients who are admitted to the ICU, you compare them to control or to diabetics, you observe that actually upon sampling or 4 hours later, there is clearly nearly no vitamin C in the blood of our patients. This is also true for some of the trace elements. And it's important to note that I'm talking to you about concentrations. Concentrations are tricky because they reflect flow between compartments. And in this case, 167 critically ill patients, normal age. And what you observe is that there is a relation between zinc and copper in outcome. And clearly, the death rate, if you have a very low one, is higher in zinc, higher with copper, higher with selenium. And this needs interpretation. I'm coming back to vitamin D because it is sort of involved also in the COVID-19. Clearly, it's been shown that the positivity of the tests is higher if you have very low values of vitamin D. Something is happening. Does it mean that we all need it? Maybe not. This is our recommendation 3 from the ESPEN Guidelines 219. And it's also, and this time we are talking about the upcoming guidelines, we needed to say that this time it's enough. Please measure CRP when you determine trace elements and vitamins, because you cannot interpret the value as being deficient if you're not considering the level of inflammation. And why so? Well, this is an important paper including over 2,000 blood samples in over 1,300 patients. And the authors have looked at increments of CRP. Copper is the only trace element which increases with inflammation. And it starts already by 10 to 20 of CRP. But all the others, here you have zinc, selenium, vitamin A, decrease with increasing inflammation without this being the proof of a deficiency. Vitamin E is little affected, but look at vitamin D. Over 40, there is nearly no normal value, and without necessary deficit. Vitamin B6, the same. Vitamin C, over 20, you have no normal value. Does it mean these are deficient? No, not necessarily. Some will have losses, and this occurs to our critically ill patients due to the disease, to our poor feeding, and to the treatments. Continuous renal replacement therapy is one of these, which shows losses of hydrosoluble micronutrients. But our nutrition is containing little. And they have fistula, they have maybe diarrhea, they have drains, the birds have cutaneous exudative losses, etc. Our poor patient, on top of that, has been sick. And this is something we showed already nearly 2 decades ago. If you measure in the effluent the losses of hydrosoluble micronutrients, you have a continuous loss. It doesn't just filter what we would like the filters to do. It also takes nutrients, it takes amino acids, etc. What does this correspond to? Well, 2 doses of parenteral nutrition, trace elements and vitamins. Major trauma, same fight. Through the drains, well, here we're talking about patients with injury severity scores of 30, severe trauma patients who stay in the ICU. The drains, the various losses, balance studies show that they are in negative balance. Major burns, of course, are the extreme. And we showed some years back, already 30 years nearly, that actually the patients were losing 20 to 40% of the body content of copper, 10% of zinc, 10% of selenium. Then we look at intervention trials. Well, you possibly already got it. My opinion is that high-dose single elements is a problem, but we can do something. Already nearly 10 years back, we thought we finally had a tool. And this is one of the meta-analyses which showed that selenium therapy, selenium alone, was actually able to reduce mortality in a significant way. Well, this was before the German trial, multicentric trial, in 33 ICUs, well conducted. But they did a 2 times 2 factorial design, which is something which can be tricky, has the advantage of testing several hypotheses, but they need to be independent, which was possibly not the case here. But the patients received 1,000 mics of selenium. The nutritional dose is 60, so we're talking about real big doses. And then this was continued with infusion over 21 days or placebo. This is the summary slide. Knowing that the groups were quite well balanced, there is no advantage in favor of high-dose solo selenium. Of course, this then, and Bill has made the work, well, the meta-analysis all of a sudden became non-significant as to mortality and barely gave a sign regarding infection. Well, vitamin D, same fight. The only studies which have shown a signal that you might be benefiting your patient with delivering high dose of vitamin D are those in the subgroup of patients which are really very, very, very low, which are probably deficient for device reasons. Vitamin C. Well, we guys in the ICU, we are treating septic shock patients. Many trials have been testing the HAT hypothesis, hydrocortisone, vitamin C, well, ascorbic acid, and thiamine, without real repeating what Paul Merrick showed. And comes the CITRIS trial, which is a single vitamin C trial. Vitamin C is special. It is an antioxidant, a very strong one, which acts on the endothelium. Well, this trial, in 170 patients, tested intravenous vitamin C, pure, for 4 days. The dose, which comes from what I'm showing you here, corresponds to 120 to 240 oranges pressed together intravenously. It's huge doses. And the primary endpoint was SOFA. And very, very disappointing. It did not show significant difference as it was calculated in the JAMA paper. But there was a problem with this SOFA calculation. They had excluded survivors or patient leaving. So the SOFA was only in survivors. They recalculated it, republished it in JAMA, and indeed, we have an explanation. It worked. It worked, and it reduced the SOFA score by 96 hours in a significant way. And this may well explain the lower mortality that was observed in vitamin C. Well, this is intriguing, needs, of course, to be confirmed, but it shows that it's important to choose the correct endpoints and to calculate them well. This was just problematic. More recently, a paper came from Saudi Arabia. This time it's not randomized. It was clinical judgment, which decided the physicians to deliver thiamine, 50 to 200 milligram to the patients coming in, to some patients coming in, and not to the others. And the authors observed a significant survival curve. Thiamine is something special because the COVID-19 patients are coming in after having eating nothing or very little for several days. So they are at risk of refeeding syndrome. And all the question is here. If you have a normal status, it's fine, your organism is working well. You cannot make a hyperimmune response. This does not work. But if you have a loss, or if you're not having sufficiently, you may either complete the intake or you may replete a loss. And this may be a single one. Or you may go into supplementation. And this impacts immunity, clearly. And here we have something that was shown 20 years back by Margaret Raymond. It was about viruses. And some mice were made selenium replete, others were made selenium deficient, and they were infected with influenza. The selenium adequate had an adequate glutathione peroxidase, modestly increased oxidative stress, had an inflammatory response, but limited organ failure. The others who were deficient had a low glutathione peroxidase response and had a massive oxidative stress and massive tissue damage. And she just remade the paradigm. Well, we know that malnutrition is causing decrease in immunity and susceptibility to pathogens, ending with infections. But if you add micronutrient deficiency, you will have an oxidative stress which will favor actually viruses becoming virulent and then favor infections. If you replete, as we did in major burn patients, actually we were able to restore immunity, which we showed, and it decreased infectious complications in major burns. If you replete in trauma, we have negative balances. You reduce hospital stay because you reduce wound healing problems. So in 2019, we said that we need to provide micronutrients to all the patients, and monotherapy should not be administered without proven deficiency. And this is the strategy we encourage. We should be delivering thiamine widely. And while we are progressing feeding to goal, we know we're not covering the needs. So we may be delivering then one multi-trace elements and one multivitamin. So here's the conclusion. The variability of the pre-admission nutrition status is important and is associated with oxidative stress and inflammatory response, which is a challenge. in case of major respiratory failure, major critical care condition, suboptimal or deficient micronutrients test reduces response capacity. You should restore it. The doses we give with our feeds are planned for chronic conditions and are insufficient. So micronutrients involved in immunity and antioxidant defenses are a special risk. And the first line is thiamine, B1, C, D, selenium, and zinc. And more research is required. And with that, I wish you a great Congress.
Bueno, muchas gracias, Mette. ¿Mette está conectada? ¿Ella me escucha y tiene traducción?
¿Te escuchas?
Oh, Mette, ¿cómo estás? ¿Qué tal?
Muy bien. ¿Y tú?
Muy bien. Muy buen español te estoy escuchando. Bueno.
Voy a ver lo que puedo hacer.
Yo voy a hacer la pregunta en español y te van a traducir al inglés, ¿ok? Perfecto.
Ok.
Bueno, tú demostraste que los pacientes críticos tienen bajos niveles de micronutrientes, lo cual no siempre implica la existencia de una deficiencia porque, bueno, hay redistribución entre los compartimentos corporales, ¿verdad? Sin embargo, y entonces eso justifica una estrategia de represión, que es diferente a suplementación o hasta una estrategia farmaconutricional, farmacoterapia con altas dosis por vía parenteral de algunos micronutrientes. En la práctica clínica de la UCI, nosotros no determinamos, no monitorizamos niveles de micronutrientes. Sin embargo, nosotros sabemos que están deficientes y que esa deficiencia o que esos bajos niveles se asocian a malos resultados de la enfermedad crítica. También, por otro lado, sabemos que deberíamos interpretar los niveles de micronutrientes en función de la inflamación sistémica y, como tú bien mostraste, el trabajo de Duncan de 2012 del American Journal of Clinical Nutrition, habría que determinar de modo concomitante niveles de proteína C reactiva. Dado que nosotros no tenemos cómo monitorizar niveles de micronutrientes, igualmente deberíamos administrar micronutrientes por vía intravenosa desde el inicio de la enfermedad crítica, aún sin monitorizar, solamente sabiendo, por ejemplo, que estos pacientes tienen altos niveles de proteína C reactiva, tanto mayores cuanto más inflamados estén.
Ok. Yo no te escucho más.
No, ahora yo te escucho perfecto.
Okay, bueno, I will answer in English. You perfectly well summarized the position I was defending. And actually, what we have done in Lausanne's trials shows that the doses we propose to deliver in the early phase are absolutely non-dangerous. I mean, I would not do any dosing in the early period because of the inflammation, you just do not know. But there are pathologies where you have losses, and they are now identified. And patients on renal replacement, patients with intestinal fistulae, patients with various sorts of, Lyell disease, etc., who have losses, you should then, after this early period, determine the micronutrients which are at risk in these pathologies. And actually, you should at least make sure that you are feeding them properly. Mm-hmm. As I said, the feeding solutions are designed for continuous feeding, not for critically ill. And the absorption during the acute early phase is also something which is variable. So this is why we encourage to go intravenously with products we know are safe. But if you do want to deliver high doses, then you need monitoring. In the burns, we also published dose finding studies, actually, and the doses we have been proposing in Lausanne are safe. You do not need to monitor because it's not available all over. So it's about the dose. No monitoring required as long as you stay within these proven safe doses.
Ok. Y una última pregunta. ¿Cuál es tu opinión con relación a la suplementación o el reemplazo en pacientes, particularmente en pacientes con sepsis, con shock séptico, del cóctel MERIC, de la terapia HAT, hidrocortisona, ascorbato, tiamina? Más allá del estudio original del CHEST del 2017 de Paul Merrick, estudios posteriores e incluso algún metaanálisis han mostrado malos resultados o ninguna mejoría con relación a esa terapia. ¿Cuál es tu posición?
Mi posición es que the doses which are used by Paul Merrick's HAT therapy are probably not sufficient regarding vitamin C as shown by Fowler. This is not nutrition anymore. I would not go in the direction proposed by Merrick because it hasn't really brought anything. It was important to explore, but there have been more than 15 trials now testing the HAT therapy. So I think the one which should be tested further is the pure ascorbic acid in septic shock, and tested further in non-septic shock patients, the administration of the very smaller, much smaller doses that are advocated at the end of my presentation.
Ok. Bueno, Mette, muchas